right, so general survey, excuse me. I'm going to begin the assessment with general survey. I'm starting at my patient's door and I'm observing my environment for safety. I'm looking for any safety hazards to myself or to my patient, which I do not see. Also observing my patient, looking that she doesn't appear to be in any distress. She's sitting upright comfortably. She's not using any accessory muscles to breathe. She doesn't appear to be cyanotic or pale. Her color looks normal for ethnicity. She looks to be awake and alert, so I'm going to go ahead and proceed as planned by knocking on the door and entering the room. Hi, good afternoon, Ms. Shaw. How are you today?
Good, how are you?
Fine, thank you. My name is Kristen. I'm a nursing student at Palm Beach Atlantic University, and I'm here today to do an assessment on you. Before I begin, I'm just going to provide us some privacy and wash my hands. Would you mind if I check your ID bracelet? And could you tell me your full name?
Trinity Shaw.
And your date of birth?
11/07/00.
Fantastic, that's correct. Thank you, Ms. Shaw. Ms. Shaw, can you tell me where you are today?
The health assessment lab.
And what brings you in?
Class.
And last, what year is it?
2021.
Super. So my patient is awake, alert, and oriented ×4. Ms. Shaw, do you have any pain I should be aware of during our assessment today?
Can I make it?
Yeah, just make it.
I have pain in my thigh.
Okay, I'm sorry to hear about the pain in your thigh. Can you tell me what happened, if you know?
I dropped the hammer.
Oh my goodness, okay. And on a scale of 0 to 10, 0 is no pain at all, 10 is the worst pain you've ever had. Right now, how would you rate that pain?
It's like a 3.
3. And when did you have this incident occur? When did the pain begin?
A week ago.
Okay, I'm sorry to hear that. Does it radiate anywhere or does it stay local to your thigh?
At first it used to go up a little bit, but now it's just
Localized to the area. Can you describe it for me a little bit more? What does it feel like?
just like a bruise. It's kind of like swollen.
Okay, and since this was related to an incident, I imagine it hasn't happened in the past or any other time of year or season. Okay, all right, very good. I'm sorry about that. Is it okay if we proceed with the exam if I'm mindful of that area? All right, very good. Okay, do you have any questions for me before we begin? All right, so I'm gonna go ahead and start with your skin and scalp. Would you mind if I touch your scalp? All right, so while I'm assessing my patient's scalp, I'm looking through her hair, I'm checking for the skin integrity, seeing if there's any lumps or bumps. I'm also observing her hygiene. I see that she's well groomed, her hair is evenly distributed, skin is intact. Moving down to the occiput, observing for any nits or lice, I do not see. While I'm there, I'm also taking note of the occiput because it's a bony prominence, making sure I don't see any redness, and if I did, that it blanches. We don't want any non-blanchable redness at the occiput, the back of the shoulders, the scapula, the sacrum, the backs of the elbows, behind the ears with the masks or oxygen, and at the backs of the heels. And again, in all these sites, I do not see any non-blanchable redness. Next, I'm going to check your skin for warmth and dryness, just using the backs of my hands, starting at the tops of your shoulders, coming down bilaterally all the way to the fingertips, and then again on the thighs all the way down to the toes, feeling that she's equally warm and dry, which she is. At the toes, checking the nail beds for capillary refill of 3 seconds or less, which it is, and edema, which I do not see. If she did, I would want to palpate to see if it is pitting or non-pitting edema. Next, on your fingertips, for me the same thing, checking capillary refill at the nail beds or the finger pads, making sure that it's 2 seconds or less on the fingertips since she's closer to the heart, and cap refill is 2 seconds or less. The next test is clubbing. Could you hold up your first knuckle for me? I'm looking for a small diamond window in between. And it's there, it's tiny, but it's there, so that's a negative finding for clubbing. Clubbing would indicate a chronic hypoxemia. Last with skin is skin turgor, so I'm going to be checking both forms. We can just pretend. Looking to see when I grasp her skin, when I release that it snaps right back. There's no tenting, which means you have good elasticity and you're well hydrated. Before I move on to respiratory, do you have any moles you're concerned about today?
Yeah, sure.
All right, so I'm going to teach you some information about this mole that can be a helpful screening tool to look for signs of malignancy or that you should have further workup done on the mole. On the non-mole, it is symmetric and the border is well defined. It is not jagged. The color is, we'll say brown. It's brown throughout. Has it always been brown? All right, the diameter is less than a pencil eraser, which is a normal finding, less than 5 to 6 millimeters. It's not elevated. Does it excrete anything out of it? Have you ever seen blood or pus come out of it?
No.
And it's not elevated, it's flush with the skin. It does not appear firm. It feels the same texture as the skin. And has it changed in any way at all, including growing in size? All right, so there's no positive findings on that screening tool for skin cancer, but if you're still worried about it, you can always see a dermatologist. All right, so next I'm going to begin your respiratory assessment. I'm going to have you swing your legs that way for me. I've already mentioned most of the inspection portion of her respiratory. Last would be that her AP to lateral ratio is 1:2. She is not barrel chested. Next, I'm going to do a couple palpation techniques on your back. Michelle, are you still doing all right? All right. Could you round your shoulders forward for me? Feeling for her spiny processes. And as I wiggle my hands down your spine, just let me know if at any time you feel any pain or tenderness. No pain? Okay. At the sacroiliac joint, any discomfort? And last is CVA. You'll feel me touching your back. At any point that causes you discomfort, again, please let me know. Discomfort? All right, that's negative for CVA tenderness. Next, I'm going to be auscultating your breath sounds or listening to your breathing. So you're going to take a series of deep breaths from me in and out through your mouth. Every time you feel my stethoscope, you just take another breath. You can get tired or windy, so if you do, let me know. We can always stop and take a break. Okay? I'm going to start at the base of your lungs. Nice big breath in and out. Super. Again. And then the rest I'm just going to mimic here, moving up and then over, up and then over, into the fossa. Arms out like a T underneath the axillary region. And all lung sounds are clear to auscultation. The next technique is palpation, checking for chest expansion. I'm going to have you take one more deep breath for me when I say. All right, go ahead. Super. And I was looking that my hands rise and fall symmetrically, which they did, which is a negative finding for pneumothorax. Next is tactile fremitus. When you feel my hands on your back, would you say for me nice and loud, blue balloon?
Blue balloon. Blue balloon. Blue balloon. Blue balloon.
Like a T?
Blue balloon.
What I was doing was feeling for equal vibrations on the ulnar surface of my hands, which was present in all areas equally. Negative finding for consolidation. And last is percussion. So again, you're gonna feel me just tapping on your back. This time I'm listening to the sound that's made. Like a T. One last time for me. All right, and all sounds were resonant. Again, negative for consolidation. You can flip back forward for me so they can see. We're going to finish respiratory by auscultating your right middle lobe, which is only heard from the anterior chest. So I'd have you take 4 more deep breaths for me. You do not have to. Starting underneath the right clavicle, listening for a full inhale and exhale, comparing right to left, down, and over. And again, we'll say that the lung sounds were clear to auscultation. All right, that completes the respiratory portion. Moving on to cardiac. You can now relax and breathe normally. I'm going to be listening to your heart sounds. I'm going to start at the aorta. The aorta is in your second intercostal space, just right of the sternal border. And my ears would be in. And then moving across the sternum to the second intercostal space, left sternal border is the pulmonic valve. Down 1 to the third intercostal space, left of the sternal border is Erb's point. Down in between the fourth and fifth intercostal space, slightly off the left sternal border is the tricuspid valve. And could you raise your arm in the air for me? I'm going the midclavicular line, fifth intercostal space for the bicuspid. This is also the point of maximum impulse and where you would listen to the apical pulse. Keeping your arm raised for me, I'm going to flip to the bell and listen to all the same vowels again, listening for duller sounds like murmurs. And that's mitral. You can put your arm down. Tricuspid. Erb's point. Pulmonic. And aortic. Okay, I heard S1 and S2 throughout. I did not hear any irregular heart sounds like S3 or S4, and I did not hear any murmurs or rubs. S2 is heard best at the aortic and pulmonic, or where it's heard loudest. S1 is heard best at the base, or excuse me, S1 is heard best at the apex, which is the tricuspid and bicuspid. All right, so I'm now going to have you lay down. And I would repeat that process again, listening to all the heart valves in a different position. What was I using? In a different position, because some heart sounds can be heard in different positions. But for the sake of time, I'm going to go ahead and skip that and move on to auscultating arteries, starting at her carotid. Listening for any whooshing sound like bruit. Can you point to the end of your sternum for me? Just below that is the aorta. Left renal, right renal, and point to your belly button. 45 degrees off, I'm sorry, is the iliac. And then I'll state femoral. Absent finding for bruits in all spots. Next, I'm going to palpate your arteries, again starting at the carotid one at a time, not using my thumb. And those are both +3. Next is the radial, comparing at the same time for symmetry and strength. +2. Stating femoral, stating popliteal, posterior tibialis. +2. Pretty good. And dorsalis pedis, +2. All right, that completes the cardiac. We're on to the very last portion of the assessment now, which is abdomen. Again, beginning with inspection, I noticed that her abdomen is flat. It is non-distended or round. Is this the normal shape of your abdomen, ma'am? And any complaints about your abdomen or symptoms of abdominal GI issue? Okay, so I'll start with auscultation. I actually did hear her bowel sounds when I was auscultating her arteries. But if I had not, I would start at the belly button and go right upper quadrant, left upper quadrant, left lower quadrant, right lower quadrant. Active bowel sounds. Next will be percussion. This will be in 9 quadrants. Point to your belly button for me so I can make my tic-tac-toe board. Okay, I'm going to start up here. And again, I'm going around in all 9 quadrants. And I'm listening for tympanic sounds. And tympany is present throughout. Next is palpation. This is to check for pain or tenderness. So just relax, and I'm going to just feel your abdomen. If at any point it's uncomfortable or painful, let me know. Any pain? All right, and then the last technique here for this is deep palpation using 2 hands. This may be slightly uncomfortable, but should not be painful. Be 3 more, which I'll skip doing to you. Okay, so that completes that portion of the assessment. The very last thing is special palpation, which is for the liver and the spleen. For the liver, the first technique is the hook technique. This is the one I actually like. Feeling for the end of the patient's rib cage, taking both your hands with your fingertips, and then having your patient take a nice deep breath. And as she does that, I'm feeling if the liver comes down and taps my finger pads, which it does not, so she's absent for hepatomegaly or an enlarged liver. Another technique you can use is to come from down low and basically just work your way up towards the patient's rib cage and see if you are able to run into the liver. I do not. And then the very last one is you can support underneath their rib cage, take your other hand at a 45-degree angle towards their costovertebral angle, basically the angle of the rib cage, fingertips in, and have them take a deep breath. As they breathe, if the liver is enlarged, it may come down and tap my fingers. Again, it does not. Technique for the spleen is just the same as that. Staying on the same side of my patient, reaching my non-dominant hand across underneath her back, 45-degree angle towards my patient's ribs, and 1 more deep breath. And if anything came down and tapped my fingertips on inhale, that would be positive finding for splenomegaly. I do not feel the spleen as well. All right, I'm going to help you sit up. That completes your assessment. Do you have any questions for me?